नमामि धन्वन्तरिमादिदेवं सुरासुरैः वन्दितपादपद्मम् लोके जरामृत्युनाशं दातारमीशं विविधौषधीनां शङ्खं चक्रं जलौकां दधतं ऋतघटं चारुतोर्भिश्चतुर्भिः सूक्ष्मस्वच्छादिरुद्यं शुकपरिविलसन् मौलिमम्भोजनेत्रं कालाम्बोधरोक्षणं कटितटविलसत् चारुपीताम्बराढ्यं वन्दे धन्वन्तरिन्तं निखिलगदमिव प्रौढदावाग्निनीलम्।
हेलो, नमस्कार डॉक्टर नवीन जी, नमस्कार and namaste to everyone, all the dignitaries. I welcome you all in the meeting. So today we are here on occasion of celebration of International Women's Day 2024 on behalf of Ayush Darpan Foundation of India, which is based on in the Uttarakhand. देहरादून बेस्ड फाउंडेशन है ये, और हम लोग इसके अंतर्गत बहुत सारे जो है वेबिनार्स कोविड काल से लेते आ रहे हैं, और उसी सीरीज का एक भाग समझिए, या एक बहुत दिनों बाद एक जॉइंट वेंचर हम कर रहे हैं कि एक आयुष दर्पण फाउंडेशन एंड महात्मा गांधी आयुर्वेद कॉलेज हॉस्पिटल एंड रिसर्च सेंटर के कोलैबोरेशन से आज हम एक इवेंट आपके सामने यहाँ पर प्रस्तुत करने जा रहे हैं, जिसका की थीम है अवेयरनेस ऑफ कोलोप्रोक्टोलॉजिकल डिसीजेस। तो मैं आप सबका यहाँ पर फिर से एक बार स्वागत करती हूँ, और आज के जो गेस्ट है हमारे डॉक्टर पी हेमंत कुमार सर, जो कि नया जयपुर में प्रोफेसर हेड है शल्य तंत्र विभाग के। सर, मैं आपका स्वागत करती हूँ। डॉक्टर मंजूषा कालमेघ, जो कि विदर्भ आयुर्वेद कॉलेज अमरावती में प्रोफेसर हेड है शल्य तंत्र में, उनका मैं स्वागत करती हूँ। डॉक्टर राजेश कुमार गुप्ता हमारे मीटिंग में मौजूद है। सर, आपका बहुत बहुत स्वागत है यहाँ पर। डॉक्टर अनीता वंजारी, डेन एकेडमिक्स, महात्मा गांधी आयुर्वेद कॉलेज हॉस्पिटल एंड रिसर्च सेंटर सालोड वर्धा, मैडम आपका स्वागत है। सांघवी सर इस मीटिंग में उपस्थित हैं, बहुत बहुत स्वागत है सर आपका। सांघवी सर हमारे एक सीनियर प्रोक्टोलॉजिस्ट है जो मुंबई बेस्ड है और बहुत अच्छा काम कर रहे हैं सर, बहुत इंस्पिरेशनल वर्क है सर का। सर, आपका बहुत बहुत स्वागत है। आलोक गुप्ता सर, जो कि हमारे आरएवी के गुरु है, एंड जो कि क्षार सूत्र के साथ बहुत सारी इनोवेटिव टेक्निक्स का जो है शल्य तंत्र की प्रैक्टिस में जो है वो उपयोग करते हैं, और सर बहुत इंस्पिरेशनल काम कर रहे हैं। तो इसी तरह से आज ये जो बहुत सारे डिग्निटरीज हमारे सामने मौजूद है, उन सब का मैं यहाँ पर स्वागत करती हूँ। और डॉक्टर नवीन जी, आप कुछ कहना चाहेंगे? एक दो शब्द आप
जी,
कहेंगे तो
बहुत बहुत
बहुत अच्छा
धन्यवाद
लगेगा
आपका।
सर।
ये जो है प्रोग्राम आपने आयोजित किया है, आपको बहुत बहुत बधाई। और दत्ता मेघे जो कॉलेज है उसके साथ में कोलैबोरेशन में हमने ये कार्यक्रम किया है। आप सभी का बहुत बहुत स्वागत है। यहाँ पे जितने भी स्पीकर हैं, मैं आप अपनी तरफ से सबकी शुभकामना देता हूँ। ये हमारा फेसबुक पर अभी लाइव है और ये यूट्यूब पर भी जाएगा रिकॉर्डेड। तो बहुत बहुत धन्यवाद आपका मैडम जी, आपने इनिशिएटिव लिया। तो आप सेशन को कंटिन्यू कीजिए मैम। थैंक यू।
थैंक यू वेरी मच सर। सर ने एक बहुत ही ब्रीफ इंट्रोडक्शन देते हुए एक सेशन का एक हम लोगों को स्टार्ट करा दिया है सेशन। तो मेरे ख्याल से हमने जो है हमारा जो आज का प्रोग्राम है ये इसी नोट पे हम लोग स्टार्ट करते हैं। और आज के इस प्रोग्राम के पहले जो स्पीकर है, हमारे सबसे पहले स्पीकर जो डॉक्टर मंजूषा कालमेघ मैडम, इनको मैं आमंत्रित करती हूँ। मैडम, डॉक्टर मंजूषा मैडम, डॉक्टर मंजूषा मैडम, यस।
मैडम को को होस्ट
आपको
बना दीजिए,
अनम्यूट।
मैम को होस्ट बना दीजिए उनको, ताकि वो अनम्यूट कर पाए।
एक मिनट, हाँ सर। सर, थोड़ी देर के लिए जो है ना, मुझे किसी की हेल्प की जरूरत पड़ेगी आज मेरे साथ एक्चुअली।
चलिए कोई नहीं, मैं कर देता हूँ, अनम्यूट कर देता हूँ सभी को।
हाँ जी, हाँ जी। और को होस्ट बनाना पड़ेगा मैडम को।
जी जी, मैं बना देता हूँ। मैडम जी अनम्यूट कीजिए आप अपने आप को।
सुनिए जाना। हाँ, हो गए। चलो चलो। हाँ, हो गए मैम।
येस मॅडम, तुमचा आवाज
हाँ
येतो आहे.
हो ये
एंड
तो है।
हाँ येस मैडम, हमारे बहुत इंस्पिरेशनल फिगर है आयुर्वेदा सर्जरी की. और मैडम जो है वो विदर्भ आयुर्वेद कॉलेज अमरावती में जो है प्रोफेसर और हेड के पद पर कार्यरत है और बहुत डायनामिक लेडी सर्जन है. तो उनके नाम इस क्षेत्र में उनका नाम काफी मशहूर है. तो मैडम, मैं ज्यादा समय ना लेते हुए आपको
नहीं,
आमंत्रित
ओके
करती
ओके
हूँ.
ओके
आप
ओके।
अपना स्क्रीन शेयर कर दीजिए.
हाँ। नमस्ते. Today's topic is कोलोप्रोक्टोलॉजी अवेयरनेस. और ये जो डिस्कशन रखा है इंटरनेशनल वुमेन्स डे के उपलक्ष्य में रखा है. तो ये लेक्चर पूरा इंटरनेशनल लेडीज और वुमेन्स के लिए सभी को नमस्ते और सभी को अर्पित करती हूँ मैं ये लेक्चर. और मेरे कोलोप्रोक्टोलॉजी अवेयरनेस के हिसाब से आज का जो टॉपिक है वो लिया है मैंने फिस्टुला इन एनो. Fistula in ano is one of the most common benign anorectal disease and difficult to treat. Next. The prevalence rate is greater in male than female. Commonly occurs in 20 to 24 years of age. Bagandhar has been included in Maha-Ashtogad Vyadhi by Sushruta. It requires surgical treatment in the majority of cases. Fistula in ano is not life-threatening condition but can have significant impact on a patient quality life. So आयुर्वेद के हिसाब से एक जो अष्टो महागत बोले हैं उसमें से एक महाअगत करके बोला है. और एक ट्रीट करने के लिए बहुत कष्ट साध्य है, क्लिष्ट है. इसलिए सभी फिस्टुला की ट्रीटमेंट करने के लिए डरते हैं. और उसमें सक्सेस रेट कितना मिलेगा, सक्सेस रेट कितना मिलेगा, इस हिसाब से हर वैद्य या हर सर्जन उसमें व्यथित रहता है. इसलिए एक योगदान करके आयुर्वेदिक इसमें एक योगदान करके बहुत सारे फिस्टुला के केसेस में हमारे डिपार्टमेंट में वर्क किया है. तो उस वर्क के हिसाब से मैं आज मेरे कुछ एक्सपीरियंसेस आपके साथ शेयर कर रही हूँ. तो इन शॉर्ट जो डिसीज है फिस्टुला एंड एनो और भगंदरा, यहाँ पे मेरे वर्क का, मेरे डिपार्टमेंट के वर्क का थोड़े एक्सपीरियंसेस और शॉर्ट में फिस्टुला इन एनो और भगंदर क्या है यहाँ पे मैं प्रस्तुत करने जा रही हूँ. Fistula in ano is a tract lined by granulation tissue which opens deeply in anal canal or rectum and superficially on the skin around the anus. Fistula implies a chronic granulation tract communicating to epithelial lined surface. These surfaces may be cutaneous or mucosal. A definition fistula की दी हुई है. Fistula means hollow structure derived from Latin word fistula, means pipe or a catheter. Next. In short, here the anatomy of rectum and anal canal. You all know the anatomy. In brief, this diagram shows the anatomy, dentate line, and sphincters, internal sphincter and external sphincter. These three things are very important in case of fistula in ano. So everyone should know the anatomy of anal canal and rectum. Causes of fistula in ano. In short, an acute abscess in one or more potential spaces around the anorectal anal canal. The source of infection, like infection in the anal crypts, anal fissure, infection from hair follicles, infection from an ulcer at the root of the pile mass, infected sebaceous gland, infected sweat glands. Another causes are foreign body penetrating from the outside, inflamed pile mass or thrombosed piles previously existing in the pile masses. Retained suturing after hemorrhoid. When we do the closed hemorrhoidectomy, there may be any suture retained in the operative site, and it may infected and formation of abscess. In case of injection treatment for the pile masses, there may be infection and other associated disease like ulcerative colitis, Crohn's disease, tuberculosis, and carcinoma. These cases are not included in this study. Mechanism of fistula formation. There are 4 stages of fistula formation: stage of infection, stage of burrowing, stage of abscess formation, and stage of secondary opening. These are the 4 stages of fistula formation. Then classification in brief: Pars classification and Morgan's classification. In Pars classification, there are 4 types as described in the slide. In the picture, there are types of fistula according to Pars classification. Then Morgan's classification. In Morgan's classification, there are 2 types. One low anal and dusra high anal. There are 2 types of fistula in anal. Clinical presentation or clinical features of fistula in anal. Perianal discharge, perianal pain, swelling or indurated swelling or abscess formation around perianal region, discoloration of skin surrounding the fistula, external opening in the perianal region. Sometimes there is an internal opening also, and there is a pus discharge from the anal region. And sometimes fever is there. And if abscess formation is there, then patient having high-grade fever. In inspection, presence of external opening in the perianal region, little red nodule may be present at the opening, induration and scar of previous operation may be there. In palpation, when we do the inspection and then palpation with the index finger, then palpation of perianal region may result in the expression of pus. A distinct cord-like induration can be felt from the external opening to the anal verge. Palpation of anal canal may detect an area of indurated or an actual opening. Goodsall's rule is there in order to help the examiner to locate the internal opening. We all know the Goodsall's rule shown in the diagram, and it is the imaginary key point to treat the fistula in anal. Site of external opening, site of internal opening, course of primary tract, presence of secondary extension, presence of conditions complicating the fistula. Some investigation, these investigation we all know. These are routine investigation: CBC, X-ray spine, USG, fistulogram, biopsy, Montague's test. Nowadays, TB PCR test is done for rule out the tubercular infection. Sigmoidoscopy, colonoscopy, and MRI is the most important investigation. Differential diagnosis. According to coloproctological disease, we should know the differential diagnosis, and these differential diagnosis. In this differential diagnosis, pilonidal sinus, perianal abscess, hemorrhoids, fissure in ano, Crohn's disease, and ulcerative colitis. There are two treatments for fistula in ano according to modern science: conservative treatment and surgical treatment. In conservative treatment, there is no permanent relapse. In surgical treatment, in many of the cases, there may be recurrence. It is observed in after study. In conservative management, this is the treatment. In surgical management, preoperative, operative, and postoperative, we all know this. Preoperative procedure. In operative procedure, there are, according to modern science, there are many procedures: fissulotomy, fissulectomy, ceton, fibrin glue, anal fistula plug, LCAF. Fissulotomy, it includes incision of the tract lying open, followed by curating the underlying tissue with the curator. All the procedures are done under spinal anesthesia with all aseptic precautions. In fissulectomy is a surgical procedure where fistulous tract is excised completely. Complete fissulectomy creates larger wounds that take longer time to heal and offers no recurrent advantage over fissulotomy. When a fistula lies either too close to sphincter or goes through it, then it is not possible to lay open or remove it without the risk of incontinence. In those cases, the treatment consists of drainage of abscess or infection along with the placement of the ceton. Ceton is derived from the Latin word ceta, meaning bristle. These material may include silk, rubber band, nylon, or polypropylene and braided steel wire. According to Ayurveda, we use Kshara Sutra or Kshira Sutra in treating the fistula in ano. Ceton are useful in the management of complex anorectal fistula where is an impressible incontinence, risk of or poor healing. We use Kshara Sutra or Kshira Sutra in case of hyoidal fistula or in complex fistula, where we can't do the fissulectomy. Then fibrin glue. A fistulous tract is closed by injection of fibrin glue, which result in formation of a clot within the fistula, helps to promote healing the cause, healing of the tract. Anal fistula plug. This is one of the treatment. Postoperative treatment. The postoperative care is as it is the postoperative surgical cases. Complications of this all treatment: recurrent infection causes pus discharge and foul smelling, abscess formation, sphincter loss. It is prone to recurrence after surgical removal. Rarely malignant changes may occur. Causes of recurrence: incomplete excision of tract, entry of new foreign body, irregular shaving of hair, improper perianal hygiene, improper drainage of pus, and other associated diseases which are untreated. This is in brief according to modern science. In Ayurveda, we can correlate fistula in ano, the disease Bhagandara. We all know the Bhagandara, but in brief, I am presenting the Nirukti Vyakhya of Bhagandara. Bhagandar Hetu means causes of Bhagandara. In Purva Rupa of Bhagandara, there is a formation of abscess. Abscess formation, and there is a pain around anal region. This is the Samprapti of Bhagandara. Previously, we described the Hetu of Bhagandara, that is Nidana Sevan, Dosha Prakav, and दूध के 2 अथवा 1 अंगुल क्षेत्र में पीड़िका formation. That pidika means perianal abscess, then raktamamsa dushti, then burst of pidika, and then there is a pus discharge around the perianal region, that is Bhaga Guda Basti Bhaga Vidarbha, and formation of Bhagandhar. According to Shushruta, there are 5 types of Bhagandhara, and according to Vagbhata, Ashtanga Sagrakar, there are 8 types of Bhagandhara. Shataponak Bhagandhara, Ushtagriva Bhagandhara, that is Pittaj Bhagandhara, then Paristravi, that is Kapaj Bhagandhara, then Tridoshaj Bhagandhara, that is Shambhukavarta Bhagandhara, and Unbargi, that is Agantuj Bhagandhara. The pathophysiology of fistula in ano described previously. One of the causes is foreign body. I described previously one of the causes foreign body. And in this shloka, the pathophysiology according to Ayurveda and according to modern science, we can correlate how the fistula formation or Bhagandhara formation is due to the foreign body. Here, Acharya Shushruta described Mudhena Mansalubdena Yad Asti Shalya Annena Saha Abhyat. यदि कोई व्यक्ति मांस का सेवन करता है, उसके साथ में अस्थि यदि चली जाती है, तो उस व्यक्ति में अवघाड़ पुरुष मीन्स हार्ड स्टूल फॉर्मेशन हो जाता है, और वो अस्थि वायु के अपान वायु से प्रेरित होके गुदा में जाके वहां पे क्षीणोती मीन्स देयर इज सम ट्रोमा एट द एनल रीजन, एंड दिस ट्रोमा जो ट्रोमा हो जाता है अस्थि की वजह से, क्षत निमित्त अस्थि का क्षत हो जाने से वहां पे ट्रोमा हो जाता है, ऊन फॉर्मेशन हो जाता है, ऊन में कोथ उपज आयते. कोथ मीन्स देयर इज इन्फेक्शन, पस फॉर्मेशन, and then puya rudhira aukindra masa kotha bhuma aviva jala prakrinayat क्रीमीय संजायते. वो जगह पे मांस कोथ, जैसे कि एक जगह पे जल इकट्ठा हो जाता है, वो इकट्ठा हुआ वो जल में जैसे कृमि पैदा होते हैं, वैसे ही वहां पे इन्फेक्शन होने के बाद वहां पे पस फॉर्मेशन हो जाता है, और गुद के पास में गुद को दारण होके इंटरनल ओपनिंग होके वह एब्सेस एक्सटर्नली फॉर्म हो जाता है, और वहां पे पेरिएनल एब्सेस की फॉर्मेशन हो जाता है. ये कोरिलेशन आगंतुक भगंदर और कॉजेज ऑफ अकॉर्डिंग टू मॉडर्न साइंस कॉज ऑफ फिस्टुला इन एजो इज वन ऑफ द कॉजेज फॉरेन बॉडी. तो एक कोरिलेशन यहाँ पे अपन दिखा सकते हैं अकॉर्डिंग टू आयुर्वेदा. देन सामान्य चिकित्सा ऑफ भगंदरा, एकादश उपक्रम, सभी एब्सेस पीड़िका फॉर्म होने के बाद एकादश उपक्रम जो बताया है, ये सामान्य चिकित्सा आयुर्वेद में भगंदर की बताई है. और बाद में शतकोनक भगंदर की चिकित्सा, जो सभी सुश्रुतोक्त चिकित्सा है, शतकोनक भगंदर, मार्गी भगंदर, उष्टग्रीव भगंदर, परिस्त्रावी भगंदर, सभी भगंदरों में एक ही चिकित्सा बताई है. वो चिकित्सा है छेदन चिकित्सा, मीन्स फिस्टुलोटॉमी और फिस्टुलेक्टॉमी अकॉर्डिंग टू सुश्रुता. और वो सुश्रुत में जो बताए हैं, सभी छेद जो बताए हैं उसमें 5 प्रकार के छेद बताए हैं: खरजूर पत्र, चंद्रार्ध, चंद्रवक्र, सूचिमुख, अवामुख, ये छेद बताए हैं. और बाद में अग्निकर्म बताया है, क्षार कर्म बताया है, और तैल का, अनुतैल का, बस्ती बताया है. ये सब कर्म सुश्रुतोक्त चिकित्सा है. लेकिन सुश्रुत में कई जगह पे आया है कि नाड़ी व्रण में क्षार सूत्र या दुर्बल भीरु नाम व्यक्ति में क्षार सूत्र की चिकित्सा बताई है. तो सुश्रुत संहिता चिकित्सा स्थान में 17वें अध्याय में नाड़ी व्रण में क्षार सूत्र चिकित्सा बताई है. तो भगंदरे अपि विधि कार्यो वैद्यने जानता अर्बुदादिषु च उत्क्षिप्त मूले सुचिर्भिव यान विराले सत्र निधापयत मूले सूत्रेण बंधीयात छिद्रे च उपरेत। तो इस चिकित्सा में अर्बुद की चिकित्सा में बताया है कि अर्बुद के बेस में यदि क्षार सूत्र आप बांधते हैं तो वो अर्बुद छेदन कर्म हो जाता है। और क्षार भगंदर में विधि बताई है एशनी के सहाय से जो साइनस नाड़ी व्रण या भगंदर का व्रण है उसकी गति देखकर क्षार सूत्र के सहाय से वो दोनों जो ओपनिंग है वो सूत्र यस्य अंत समानीय गाढ़ बंध समाचरित, सूत्र के सहाय से वो गाढ़ बंध से बांध देना चाहिए। कब तक बांधना चाहिए? ततक क्षार बलम वीक्ष सूत्रम अंत्य प्रवेशित, क्षार का बल जब तक कम नहीं होता। इसका मतलब 7 दिन के बाद या अकॉर्डिंग इट डिपेंड्स अपॉन द वैद्य, वो कितने दिन में बदल सकता है। क्षार का बल कम हो जाने के बाद वो क्षार सूत्र चेंज करना चाहिए। तो ये चिकित्सा का रेफरेंस लेके शुश्रूषा संहिता का क्षार भगंदर में क्षार सूत्र चिकित्सा करने का क्लू यहाँ पे मिलता है। तो क्षार सूत्र निर्माण विधि चक्रदत्त ने बताई है।
मैडम मैडम सॉरी टू इंटरप्ट, प्लीज थोड़ा सा टाइम कंस्ट्रेंट का ध्यान रखते हुए थोड़ा सा वाइंड अप करिएगा।
ये क्षार सूत्र की जो चिकित्सा है ये सभी को मालूम है। मैकेनिज्म ऑफ क्षार सूत्र इन फिस्टुला इन एनो ये भी सभी को पता है। तो लास्टली आई वुड लाइक टू शो माय सम cases, interesting cases which are treated by Kshar Sutra therapy. This is the case of fistula in ano. Here there is a Kshar Sutra and treatment, and last photo of patient cure. Okay. Next. This is the case of 8-month-old child, fistula. There is a pointer. This is Ksharvarti dressing. Then Kshar Sutra Pravishta. Changing. This is the another case. There is a multiple fistula up to the thigh. The next Kshar Sutra application. And last photograph. Complete cure of the patient. Another case, tubercular fistula, known case of tuberculosis, multiple opening and high anal fistula. Kshar Sutra applied. And last photograph. Another case, after post-operative treatment. Here another case, before treatment, during treatment, and last photograph. Another case, complete cure of the patient in the last photograph. This is partial fissulotomy and Kshar Sutra treatment. This is the case. First we apply the Kshar Sutra, then fissulotomy, and last photograph. Another case, these cases are partial fissulotomy, fissulectomy, and Kshar Sutra. These are the different cases. This is the case of pilonidal sinus. Another case. This is the before and after treatment. Another case of operated fistula. These are the cases. So these are the some interesting cases or case series of which are done in our department. So thank you. मुझे आप इस वुमेन्स डे के इंटरनेशनल वुमेन्स डे के प्रोग्राम में यहाँ पे मेरा वर्क प्रेजेंट करने के लिए आमंत्रित किया है। तो मैं शीतल मैडम के आभारी हूँ। वैसे सभी जो टीम है उनके आयुष दर्पण की सभी की मैं आभारी हूँ। और मुझे दो शब्द और मैं जो एक्सपीरियंस है उसके लिए मुझे यहाँ पे आमंत्रित किया है, मैं इसलिए एक बार और आभार व्यक्त करती हूँ। मैं आपकी ऋणी हूँ। और वुमेन्स डे, इंटरनेशनल वुमेन्स डे के सभी को शुभकामनाएं देते हुए मेरे यहाँ पे मैं मेरा प्रेजेंटेशन खत्म कर।
थैंक यू मंजूषा मैडम फॉर अ वेरी नाइस प्रेजेंटेशन। आज बहुत दिनों बाद मैडम आज पूरा शास्त्रोक्त फिस्टुला के बारे में जो भी आपने जो वदंती की है, तो एक बहुत अच्छा रिवीजन हो गया हम सबका। और उसी के साथ साथ आपने एक बहुत सक्सेसफुल आपकी जो स्टोरीज बताई है फिस्टुला की, तो मुझे बहुत ही अच्छा लगा कि बहुत सारे केसेस, वैरायटी ऑफ केसेस आपने दिखाए। तो मैडम बहुत बहुत धन्यवाद आपका। और
थैंक
बहुत अच्छा आपने एक ओपनिंग बैट्समैन का जो रोल है बहुत अच्छे से अदा किया है। थैंक यू वेरी मच।
यू।
आप
थोड़ा
हमारे साथ
टाइम
बने
लगा
रहिए।
मैडम।
जी मैम। नहीं, आप हमारे साथ है, ये हमारे लिए भी बहुत मतलब एक हमारे लिए बहुत अच्छी बात है कि आप जैसे सीनियर व्यक्ति आज हमारे साथ है, जो कि एक डायनामिक सर्जन भी है, जो आपके वर्क से भी यहाँ पर विदित हो रहा है। सो थैंक यू वेरी मच वंस अगेन। सो प्लीज हमारे साथ बने रहिए, और हमारे साथ बहुत इंटरेस्टिंग स्पीकर्स है, तो उन सब का हम आज जो है लेक्चर सुनेंगे। सो विद दिस आई कॉल अपॉन डॉक्टर परलोपोथुरु हेमंत कुमार सर। सर का नाम जो है वो नाम ही काफी है। हमारे क्षेत्र में ऐसा कोई व्यक्ति नहीं होगा कि जो सर को जानता नहीं है, हेमंत कुमार सर को। तो एक जस्ट एक फॉर्मेलिटी है जो कि मैं सर की एक ब्रीफ इंट्रोडक्शन आज के सब जो यहाँ पर बच्चे हैं, खास करके पीजी स्टूडेंट्स, उनके लिए पढ़ देती हूँ। सो डॉक्टर पी हेमंत कुमार सर, जो कि हम सबके सीनियर है, बहुत अच्छे आयुर्वेदा सर्जन है, प्रोफेसर एंड हेड है एनआई जो है नेशनल इंस्टीट्यूट ऑफ आयुर्वेदा के पीजी डिपार्टमेंट ऑफ शल्य तंत्र में, जो डीम टू बी यूनिवर्सिटी है। और बहुत इंस्पिरेशनल वर्क है सर का वेरियस फील्ड्स में, जैसे कि राइट फ्रॉम द आयुर्वेदा सर्जरी टू आयुर्वेदा ऑन्कोलॉजी। सर का जो है सर पीजी पीएचडी धारक है। सर के अंडर बहुत सारे 21 पीजी स्टूडेंट्स ने आज तक काम कर चुके हैं, और बहुत सारे पीएचडी स्टूडेंट्स भी सर के अंडर काम करते हैं। Guided many things. Number of surgical and parasurgical procedures performed are more than 50,000. Number of publications 119, books 5, awarded with many awards like Acharya Award, Sushruta Ratna Award, Best Teacher Award, Bhishak Janahit Manch, Young Sushruta Award, Best Teacher, Vagbhat Bhushanam, एंड मेनी अदर्स। सो एक बहुत ही ब्रीफ इंट्रोडक्शन सर मैंने आपका सबके सामने दिया है, लेकिन हम लोग सब बहुत जो है वेट कर रहे हैं आपके प्रेजेंटेशन का। सो डॉक्टर हेमंत सर विल बी प्रेजेंटिंग ऑन सर्जिकल ऑन्कोलॉजी इन टुडेज प्रोग्राम of which is having the theme of awareness of coloproctological diseases. Thank you very much, sir. Welcome.
Namaskar, madam. Namaskar. And I am very thankful to Ayush Darpan and Varda. Really, it's a great opportunity and propagating our, especially for Ayurvedic surgery. And first of all, happy International Women's Day. And given the topic of surgical oncology in Ayurveda, it's my experience what I am practicing surgical oncology in Ayurveda and treating cancer patients that I am going to focus today. I will share a point. Madam, slides are visible.
Yes, sir.
Shall I go for full screen?
Yes.
Okay. In between any problems, voice or audio, kindly inform, madam.
Yes.
Okay.
Yes,
Yes, madam.
definitely.
And I will complete within stipulated time. Definitely. I hope. Definitely.
Yes, sir. Sure.
Slide show, madam. Now it is visible.
Yes, sir.
Okay. Shall I go, madam? Slides are moving.
Yes.
Yes. Om Dhanvantaraaya Namaha. Om Manjunadaya Namaha. Respected faculty members, respect experts from the field of Ayurvedic surgery and various stalwarts in the Ayurvedic surgery joined in this webinar, and my dear students and other surgeons. Today we are going to discuss about surgical oncology in Ayurveda. See, before going to that, brief about our institution. This is our institution. It's a National Institute of Ayurveda, deemed to be university, NAC accredited and NABH accredited. And see, these are some of the facilities available in surgery department, especially Shalyatantra. So we have anorectal unit, general surgery unit, and orthopedic and marma chikitsa unit, endoscopic unit, IPD, and we have a good operation theater. See, this is another very important practice in our department, surgical practice by hands-on training to the students. This is our unique vision of our department, hand-to-hand surgical training to our PG scholars. See, these are the various major surgeries we performed in our theater in National Institute of Ayurveda, Jaipur. See, orthopedic surgeries, and we have a wonderful team, orthopedic Ayurvedic surgeons in our institution, operating all types of orthopedic cases, including open reduction, closed reduction, etc. Plastic surgeries and anorectal surgeries, minor surgical procedures, marma chikitsa, bloodletting procedures, agni karma, kshara karma and kshara sutra, laparoscopic procedure. We started 2 years back, and more than 40-45 cases we operated lap poly in our institution, and laser surgeries. And we have different gadgets like video rectoscope, fistuloscope, and we have wonderful yoga karmagar, that is yoga lab, stimulation education lab for training of our PG and UG scholars. So this is another advanced multi-purpose tool, and CPR. And within short, we are going to purchase laparoscopic simulator and broncho, colono and gastro simulator. And I really appreciate the Ministry of Ayush and our Honorable Vice Chancellor. We are going to start the modular operation theater within short in our institution. See, these are the various surgeries from last 12 years. See, coming to cancer in Ayurveda, see, 1 million new cases detected every year in India. So this is the recent statistics. 3 to 3.5 lakhs die every year due to cancer in India. 1 Indian in every 8 to 10 will get cancer in her lifetime. Cancer will be the #1 cause of death in developing countries by the middle of this century. Expected number of new cancer cases in Rajasthan is 1,50,000 cases every year. See, this is very important. We all joined, all systems of medicine must join hands. You see why? Because Ayurveda and allopathic system and integrative yoga and all these things is very important role of treating cancer patient. See, arbuda is derived from the root arb with the suffix "na" along with augmentation of "nd". That means grammatically it denotes the fleshy outgrowths is called arbuda. See, these are the malignant diseases in Ayurveda. The question arises: the malignant diseases are mentioned in Ayurveda or not? Yes, malignant diseases are mentioned in Ayurveda in various contexts, in various places. See, we can categorize it into 3 groups. Group 1, it is purely clear malignancy like Mamsa Arbuda, Rakta Arbuda, Mukha Arbuda, Tridosh Arbuda, Gala Arbuda, Ashadya, Vrana. See, diseases considered malignant like Mamsaja Ostaroga, Galaga, Ashadya Galaganda, Lingasha, Tridosha Gulma, Asadya Gulma, Chayaja Kasa, that is bronchogenic carcinoma. These are all the references available in our classics. Group 3, suggestive of malignance. Why? Because you must to rule out it, the malignance may chance or maybe precancerous condition like Chataja Visarpa, Tridoja Nadivrana, Tridoja Pradara, etc. See, what are the common cancers we observed in our normal practice? One is carcinoma of esophagus, CA breast, and CA of liver, CA gallbladder, CA lung, CA colon, CA rectum, CA urinary bladder, CA prostate, CA testes, carcinoma of the genital organs, malignant melanoma of the heel skin, right fillets of the breast, other rare cancers, and hepatocellular carcinoma, carcinoma of the cheek, non-Hodgkin's lymphoma, squamous cell carcinoma, soft tissue sarcoma. See, these are the various common and rare cancers are normally seen in our practice. And according to our textual, Susruta mentioned there are three types, especially medical management, parasurgical management, Shalya Chikitsa, and combination of anything. That is surgery followed by medical management, surgery followed by parasurgical management like Shara Karma and Agni Karma, etc. See, parasurgical treatment, there are various references available. Brakta Mokshana, they mentioned. Agni Karma. See, nothing nowadays we are practicing radiotherapy activities. Management, it comes under Agni Karma. And application of Agni Karma by macro method and micro method. See, some of the cases, this is a benign tumor, but it is a polypoidal growth. We excise it followed with Agni Karma. And Kshara Karma, we treated some of the patients of metastatic tumors. If not respond, not already excised the tumor, sometimes they developed metastatic external tumors. We can go for Kshara Karma. There is a reference available in our classics. See, this is the case we can see is a dermatofibrosarcoma. We treated, it is a spindle cell mesenchymal neoplasm. So you can see preoperative, after resection, followed the application of Pratisaraniya Tikshakshara. See what I am focusing here, we treated in our hospital and follow case of histopathological study of the same report. And maggotification, also we are practicing in our institution, and this year we are trying to breeding of maggots. See, this is the maggotification method. There is two types of maggotification. Susruta usually mention natural maggotification like paste of nishpava, pinyaka, mamsa, takra, etc. to apply on infected wound or infected cancer to attract flies. It attracts and worms and parasites produced and will consume the tissue of arbuda. Remnant unconsumed arbuda will go for either surgery or lekana and agni karma. So I will share my experience here. See, these are the drugs we collected: nishpava, pinyaka, kulutta, mamsa, takra, and prepared as a paste formation. We applied external growths. So this is the case of carcinoma of the breast. Actually, we are planning for this case by surgery. And what is a very fixed growth, very difficult to go for surgery. It needs more vascularity. Then we applied maggotification and followed the application of, followed by Chedana, that is radical mastectomy. And the completely skin is removed. Why? Because it is affected the skin surface. Then we did the skin grafting also. Then recurrent post-operative case of chordoma. It is a malignant tumor of sacrum. See, this is already operated and developed metastasis and external growth, and we applied natural maggotification. See, this is another case. This is a very interesting case. You see, this patient is already operated surgical excision of the carcinoma of the cheek and followed by chemoradiotherapy. Again, there is a recurrence. Then this patient we treated with, patient is unable to take the water also. Then we treated with maggotification. Patient is, but it is not a I can't say it is not a permanent cure for that, at least to relieve this patient, to reduce the growth of the tumor and reduce the vascularity. See, this is another case of post-operative case of oral carcinoma. This is another case of squamous cell carcinoma of the heel. See, this is the main mega diff. Now we started go for natural available maggots, or we are going to breeding of these maggots, especially Finacea sericata. This is the maggot can kill the bacteria and stimulate wound healing and biofilm inhibition and eradication of the ulcer or maybe malignant tumor. See, coming to surgical oncology, as a surgeon, in my practice, what are the surgical conditions I operated in cancers? See, usually Shalyachikitsa, Susuta mentioned, is a different method. If not responding with medical management, the Susuta advised Chedya Bagandhar. That means surgical excision, followed by Lekana Karma, Agni Karma, and Chara Karma, followed by the wound management of Rana Sodhana and Rana Ropana. So this is the actual Ayurvedic line of treatment mentioned by Susuta till we are practicing. See, any cancer, maximum number of cancers, diagnosed cancers, organic cancers, the treatment is surgical excision. Sushruta mentioned clearly, Chedye Arbuda. If you go for Ashtaveda Sastra Karma, he mentioned about Chedye Arbuda. That means excision is the first line of treatment of cancer. That is must to remember. Why? Because we are seeing that so many places they're treating the cancer with medical management and treating and trials and trials. It is not a correct way. If you diagnose a cancer, the patient is willing, or you can convince the patient for surgery. Surgery is the first line of management in cancer management. See, these are surgical oncology goals. Main is cure, control, palliation. This is very important. See, if you go for surgery, we can remove the tumor and follow the control of infection or control of metastasis and followed by the palliation treatment. In palliation treatment, we can go for our Ayurvedic adjuvant therapy or maybe chemotherapy or radiotherapy. It is helpful. See, these are the important modalities in surgery, like surgical intervention, radiotherapy, chemotherapy, gene therapy, stem cell and bone marrow transplants, immunotherapy. Nowadays, maximum in place of chemo, they're replaced by the immunotherapy with less side effects. The principles of surgery in malignancy is screening, diagnosis, surgical treatment, and prevention. This is very important guidelines or principles of surgery in malignancy. See, these are the World Cancer Research Fund International, the cancer prevention recommendations they given to maintain the lifestyle, regular diets, and physical activity, and mental activity, meditation, and stressless life. And these are all very important role to prevent cancer. See, these are the steps in treatment: palliative, cure. The main goal is relief or control of the symptoms and maintenance of the quality of life. That is very important. We have treated so many after surgical excision, followed by our Ayurvedic management and yoga, especially meditation. It increases the quality of life and increases the lifespan of the patient. See, the surgical removal of the entire cancer remains the most frequently used treatment. See, Susuta also mentioned same point, and till today, the Cancer Society also mentioned the first line of treatment is surgery. Surgery may be primary or prophylactic, palliative or reconstructive. See, of the first line of choice for solid tumors whenever possible, especially CA breast, uterine cancer, cervical cancer, lung cancer, and bone cancer, or different organic cancers, you better go for surgery. See, in common types of surgical intervention in oncology, either diagnostic surgery like biopsies, histopathological examination for confirmation, primary tumor resection, reconstructive surgeries, resection of metastasis after surgery, palliative surgery, and cytoreduction. Sometimes in gastric cancer, it's not possible to operate, or maybe patient come for delayed with metastasis, then you can go for palliative surgery, you can go for bypass or other palliative procedures. See, these are the surgical intervention in oncology by resection, metastasis resection, palliative, reconstructive, and diagnostic. See, these are some of the cases I'm going to discuss. See, excision of tumor here. It's a simple lipoma. It's a neuroma. We treated one case, but it is a benign tumor at brachial plexus. We did under general anesthesia. We removed the neuroma. And carcinoma of the penis under local anesthesia. We excised the carcinoma of the penis, penile amputation, followed by the radiotherapy. Then breast carcinoma, already you have seen this patient, megatortification, followed by the radical mastectomy, followed by the grafting. And breast, this is another case of breast carcinoma, radical mastectomy. See, that's why if you diagnose it, especially in females, breast carcinoma is the easiest complete eradication of the treatment in cancer of the breast by surgery. And this is another case of I treated CA breast, the radical mastectomy along with the axillary cleavage. This is another case of breast carcinoma, radical mastectomy. And this is another axillary resection. And carcinoma of the thyroid, thyroidectomy. So giant ovarian tumor, actually it is a benign tumor, but to be excision with the tumor of ovary. This is another interesting case we operated, I think in SDM College of Ayurveda, Hassan. It is a diagnosed case of, you can see the patient is around 9 years female patient, and the huge swelling, looks like a pregnancy. And the diagnosis as a huge lipoma in the mesocolon. Then we treated this patient. We removed total lipomatosis growth. It is approximately 5.6 kgs. It is almost that time it is covered in all media, and we operated in our Ayurvedic hospital. And this is another case of gastric, and especially it's very rarely you can see the duodenal cancer. So we did gastrojejunostomy and carcinoma of the stomach by partial gastrectomy and gastrojejunostomy, that is Billroth 2. And inguinal hemangioma. This is also a small female patient. We operated under local inguinal hemangioma. And this is another case of inguinal hemangioma. This is also another case of, so maximum cases we treated the hemangioma with followed excision. It's very important. It's proper diagnosis and proper excision. And see, if you say benign anal canal growth, any anal canal growth, you must to go for biopsy. If you doubt other than hemorrhoids, other than polyps, you must to go for biopsy, then confirmation. See, patient came like this. It's a very interesting case. I'm concluding session. This is one of the important 69 years old male patient complaints of intermittent pus discharge from perianal region since 4 months. Pain and swelling in perianal region since 4 months, and previously operated for fistula in ano before 8 years for 2 months, 2 times. So you can see, if you see this patient, everybody will diagnose it like it is a fistula, then you have applied for Kshara Sutra or in the fistulectomy, etc. But it's very important. It is a different look than fistula. Then I did biopsy. See, and MRI scanning report, they given as a irregular growth, or you can see the small tract and irregular fibrous bands in the right ischianal ischorectal fossa. And under local anesthesia, we did some collection is there, drainage followed by the biopsy, debridement followed by the biopsy. And you can see the pre-operative, intraoperative, first and fourth post-operative day. See, histopathological reports suggest you of moderately differentiated adenocarcinoma. See, this is very important. See, diagnosis part also important. And next step, you can go for sphincter sparing procedures. We can go for anastomosis. If the sphincter is involved, you can go for permanent colostomy. See, does surgery cause cancer to spread? One common myth about cancer is that it will spread if it's exposed to air during surgery. Some people may believe this because they often feel worse after surgery than they did before. Another reason people may believe this is because during surgery, the doctor may find more cancer than was expected from scans and X-rays. This can happen, but it's not because of the surgery. The cancer was already there. It just did not show up on the test that way. This is very important. ये myth है. The patients का believe है सर्जरी करेंगे तो कैंसर बढ़ जाता है. ये गलत है. Doctors, you must to advise the first line of management is surgery. That is our duty of a doctor. Cancer does not spread because it has been exposed to air. See, the clear concluded that the cancer will not spread by the surgery. See, these are the various research works on cancer. And very important is Patya is very important in cancer management, both the preventive aspect and curative aspect, and post-operative management and post-operative treatment. You must to go for Patya and Apatya, what they mentioned by the Ayurvedic classics. This is Patya and this is Apatya. See, this is my home message. Better to screen. That is proper screening in OPD. Number 2, diagnose properly with different aspects. Maybe colonoscopy, maybe gastroscopy, or maybe histopathological examination. You must to go for proper diagnosis and plan for treatment. See, this is not my words. It is the words of Cancer Society. Maximum number of cancer patients, the first line of management is surgical intervention. Susruta already mentioned by Chedye Bagandar. First line of management is cancer, is surgery. To treat the patient ethically, we must not try on our own experiments on cancer patients. This is very important. Keep in mind. I have seen that you can treat by our medications or some other thing. And better you can think about patient is our own family, how we can interact, how we can react, can treat the patient. My sincere advice of the doctors and students, proper screening, proper diagnosis, and better go for exact ethical line of treatment is first. See, these are my Susrutas trained me in my career, like Professor J.C. Prasad ji, K.R. Sharma ji, Manoranjan Sahu ji, Prasanna Rao sir, and Dr. Gopinath, Dr. Manoj Pratap Singh, Dr. Sivji Gupta ji, Dr. Ravi Shankar sir. These are my Susrutas, what I am practicing and what I train from various, my teachers, my gurus, and my friends, and my colleagues, and my students also. They are all real my Susrutas in my life. See, this is our teamwork. Without teamwork, we can't success in surgery. This is our excellent teamwork in National Institute of Ayurveda under the guidance of Professor Sanjeev Sharma ji, the Vice Chancellor, and my colleagues, Dr. Ashok ji, Dr. Narendra ji, and modern surgeon and anesthetist, and other faculty members like Dr. Shuman Madam, Dr. Sapna, Dr. Manorama, Dr. Lokender, and all faculty of, especially for nursing staff and my PG scholars. See, without success, without teamwork, there is no success. This is my success in teamwork in NIA Jaipur. Thank you. Thank you listening my talk. Once again, thank you to Seetala Shatkara Madam. Thank you, Madam.
Thank you very much, sir, for such a wonderful talk on surgical oncology. Sir, we got to know about the variety of cases you are doing at your institute level about onco and Ayurveda aspect to in treating the oncology part of the diseases. Means you have actually brainstormed the students today. They have got a lot of vision today ki how to treat the cancer through Ayurveda modalities. So बहुत ही अच्छा लगा सर आपका वो टॉक सुनकर और मेरे ख्याल से सभी स्टूडेंट्स आज इंस्पायर हुए हैं कि कैसे हम सुश्रुत के वेरियस प्रिंसिपल्स को ऑन्कोलॉजी में यूज कर सकते हैं. सो थैंक्स वंस अगेन फॉर ज्वाइनिंग सर एंड थैंक्स कि आपने हमारा रिक्वेस्ट एक्सेप्ट किया. आयुष दर्पण एंड महात्मा गांधी आयुर्वेद कॉलेज की तरफ से मैं आपका बहुत बहुत शुक्रिया अदा करती हूँ. थैंक यू वेरी मच.
नमस्कार मैडम. नमस्कार.
सो विद दिस एक बहुत वंडरफुल स्टार्ट मिला है प्रोग्राम को जो कि आज का हमारा इंटरनेशनल वुमेन्स डे सेलिब्रेशन है और इसके लिए हम यहाँ पर आज उपस्थित हुए हैं आयुष दर्पण और महात्मा गांधी आयुर्वेद कॉलेज हॉस्पिटल एंड रिसर्च सेंटर सालोड वर्धा की तरफ से. तो आज हम लोग हमारे प्रोग्राम में जो थीम लिए है दैट इज अवेयरनेस अबाउट कोलोप्रोक्टोलॉजिकल डिसीजेस एंड विद दिस वी आर मूविंग अहेड टू द थर्ड स्पीकर फॉर इन टुडेज प्रोग्राम. So may I call upon Dr. Anita Vanjari, who is Dean Academics at our institute, that is Mahatma Gandhi Ayurved College Hospital and Research Center, which is the constituent college of Datta Meghe Institute of Higher Education and Research, Savangi, Wardha. तो यहाँ पर मैडम हमारे डीन अकेडमिक्स पद पर है और मैडम का आईपीआर का जो एरिया है वो बहुत स्ट्रांग है. she has bagged with reputed patents to her credit on various topics. तो आज मैडम हमारे यहाँ क्षार सूत्र स्टैंडर्डाइजेशन एंड इट्स नीड पे बात करने वाले हैं. So I welcome Dr. Anita Vanjari, who is one of the very good friends of mine, and we are honored that she is here in our meeting today. Welcome, madam.
Thank you very much, ma'am. If I'm audible? Hello?
Yes,
Hello?
you are audible. Yes, yes.
So, good evening to all. I'm really thankful to Dr. Naveen Joshi sir and Shital ma'am who have given me this opportunity to share my thoughts on this great platform, international platform. So, actually, what I think that it is odd man out. I am from Russia, and such a great surgeons are here in this presentations. But then too, I will play my role.
Yes, definitely, madam. You are definitely not odd man out, and you are Rasa Shastri, so you are talking on a relevant topic. So please make it full screen, and
Yes.
it will be very much visible to the audience.
So my today's deliberation is on Kshar Sutra standardization and its needed. So myself, Dr. Anita Vanjari, I'm a professor in the Department of Rashashastra and Vaishya Kalpana, as Madam already introduced me. So without wasting time, I will move to the next. So the contents of this deliberation is need of Kshar Sutra standardization and what are the standardization parameters we are using and what is its significance related to clinical practice. So when we are saying that what is standardization, it is getting same result every time. Same result, same quality every time. This is a simple definition of the standardization. There are so many definitions related to standardization, but it's a very simple to get understand. So like we are getting same thing at every time. So we are saying that it is a standard. What is the mechanism of standardization? Under the standardization, right from raw material assurance to the final product, both it is a mechanism. So under that, quality assurance of the raw material, it is also one of the important part. Then in process quality control. So when anything is manufactured, so we are have to work out regarding the end point and proper code. In related to Kshar Sutra, we are having a proper coating, proper drying. All these are the in process quality control assurance we have to take care. After that, what are the product we are getting? It is a of good quality. And again, its standardization is also required. After preparation of the Kshara Sutra, the storage condition also play an important role. So this mechanism of standardization, it ultimately leads to the getting the optimum result on the patient, and as it is one of the key of success, good medicine. So when we are thinking about the Chatushpada, it is one of the important part. Bhishak, along with Bhishak, Bheshari is also important part. So this Shara Sutra is also very, very important. If it is not prepared properly, then it may it may result in so when we are saying that what is the need of standardization? That is my concern for today's my lecture. When I am saying that getting same result every time, getting same quality every time, ultimately it results into the patient's compliance. Under the standardization parameters of Shara Sutra, we are having different parameters. We are having organoleptic parameters, physicochemical parameters. Then under physical parameters, we are having minimum tensile strength, diameter, thickness of the thread after coating, HPTLC, and the microbial load. So all these are the parameters which are very much important in when we consider the standardization of the Kshara Sutra. Organoleptic parameters, these are from these we are getting with the color, order, and texture only. So with the Panchagyanendriya only we can identify them. But it is a major checkpost, prime checkpost rather, where we can, if the color it is not proper, if order is not proper, then we can reject the material at that time only. Thickness of the thread and diameter, both these parameters, they are related to uniformity of the Kshara Sutra. The tensile strength, it is related with the durability. HPTLC, it is a chemical parameter, and it relates with the chemical phytoconstituents or active constituents in the drugs which are used for the Kshara Sutra preparation. So all these are the very important parameters. And apart from that, physicochemicals are important. Under that, pH is very important. So if you see the tensile strength, what is the objective behind tensile strength? That how much load a material can withstand when loaded in tension. And if you see that the standard value, it should not be less than 5 kg. So it is very important that it should have a proper tensile strength to do its work. For maintenance of the uniformity, you have to check care of the weight, diameter, and the thickness throughout the thread. When we are saying that thickness throughout the thread, it means that the uniform coating should be there over the thread. Under the physicochemical parameters, we are having pH loss and drying at 105 degrees centigrade. Then extractive values, sulfated ash values. Ash values, we are total ash, acid insoluble, water soluble, and sulfated ash. These are very important parts in ash value. Then total alkalis, which are calculated as a carbonates, and acid for the minerals which are present in the Kshara. So as we are saying that it is a Kshara Sutra, when we are saying that Kshara Sutra, so obviously we are using the Kshara in this whole preparation. So obviously, as we are using Kshara, the pH must be the alkaline. The alkaline pH, it results in the scrapping. So when it is alkaline in nature, it also doesn't allow the rectal pathogens to invade the cavity. As we are saying that the Sharanata Ksharaha. So it is there. obviously it is there with the Shara. But apart from that, if you see that it doesn't allow the rectal pathogens to grow in the cavity. Nowadays, what we are finding that the enhanced debridement, what we can say that it is a Sharan only, nothing other than that. So the researchers, they are finding that it break down the necrotic tissues and loosen its adherence to the healthy tissue and facilitating easier removal of during dressing changes. So this thing happens on account of the Kshara Sutra. And the pH which is there, which is alkaline in nature, on account of that, we are getting this debridement enhancement. And it is not only the removal of the necrotic tissue, but it removes the, it facilitates the removal of these tissues during dressing. Apart from that, control sclerotic effect we are getting. It allows the targeting on the unhealthy tissues and minimizing the damage to the surrounding healthy areas. So this word sclerotic effect is there, and it is to the controlled one, which allows targeting only unhealthy tissue. So it is a very important fact we are getting out of the pH, that is particular alkaline pH of the Kshara. It also stimulates the granulation. Whatever the scrapping is there, on account of that, the mild irritation is caused. And it stimulates the growth of granulation tissue, and which is required for the new tissue formation and the wound closure. So this pH plays an important role in the Kshara Sutra. Apart from that, some physicochemical parameters are loss on drying at 105 degrees centigrade, which is also known as a moisture content. And this moisture content, it is related with the shelf life. So when we are saying that moisture content, it is more than the required or desired, in that condition, its shelf life will be deteriorating. As we are knowing that Kshara we are using, so it is having the hygroscopic in nature. So it absorbs the moisture from the atmosphere, and deterioration of the Kshara Sutra may happen. So it is very important that to assess the LOD, and which is done at 105 degrees centigrade. Extractive halo is another important parameter in Kshara Sutra standardization. In extractive halos, we are doing the water soluble extract, alcohol soluble extract, hexane extract, etc. So these extractive halos, they will direct for the potential which is present in the Kshara Sutra. So it gives the direction in that way. It is also one of the very important parameter. In Kshara Sutra, ash value analysis is another parameter in that for assessment of inorganic material which is present in the particular formulation, we are using the ash value analysis. So here sulfated ash is an important part in Kshara Sutra. So by means of that, we can assess that if any inorganic material is present in the end product. Then as we are saying that they are Kshara. So Kshara Sutra prepared with the Kshara. So total alkali count, it is also needed. And it is which are useful for the scrapping, cleansing. All these are the properties which are related to the Kshara only or alkali only. And it is expected that they should be more than 20%. They should not be less than 20% actually. So it is the standard limit which is given. Apart from that, the mineral acid should be done. So what is potassium, sodium, the quantification if you can do. So by means of FTR analysis, we can assess other things also. The HPTLC is an important part in standardization. So whatever the drug you are using, whatever the herbs you are using for the Kshara Sutra Nirmana, that standard should be run along with your formulations, extract of the formulation. And by means of HPTLC, you can assess that the qualitative assessment of phytoconstituents can be done, as well as the quantitative assessment can be done. So if I am saying that my Apamarga Kshara, I have done that much of coating. So by means of TLC only, I can get ki Apamarga Kshara, Apamarga is used or not. But when I am doing the HPTLC, by means of that, I can assess or quantify the percent quantification of the Apamarga, the standard which I am using for the Apamarga, or the curcumin layers if I am using. So by means of that HPTLC, I can assess the qualitative and quantitative parameter and the phytoconstituents which are present. According to the use of the phytoconstituent, they can be assessed. Then microbial growth, it is also very important. As we have already discussed that it is as it is hygroscopic in nature, it can absorb the moisture from the atmosphere and it leads to the contamination. Hence, it is needed to assess for the microbial growth and absence is required. There should be no growth. So microbial load should be absence. So it should be free from any microbial contamination. You should take care of it. Because whatever the area Kshara Sutra it has been used, it's prone for the infection. And already there are some infections or there may be some infections. So you have to take care of that thing, that it should be free from any kind of contamination. Apart from that, storage condition, as we are saying that it is having the, as it is having hygroscopic in nature, so it is required that its storage condition should be proper. So it should be placed in the desiccator or in the container with the silica material. So if I have here, it is a Kshara Sutra generally which we are getting. But if the silica pouch, if it is placed in that, so it will absorb the moisture. So it is a very simple thing which you can do at your level. And by means of that, the moisture content can be reduced. And ultimately, you can get a better shelf life of that. So actually, Kshara Sutra, you people must be, all are the surgeons. You must be getting it at your own hands. But while preparation, so many cares has to be taken, what I think, to get an ultimate outcome. So accordingly, I have tried this, my little effort to orient you people regarding that. And as I'm having a very less time to, the time which is given is very less. So accordingly, I have placed it in front of you. So my take home message is only that this is an area where some very little work has been done in Kshara Sutra standardization. So this area should be strengthened, and some researches are needed to be done on that area. So with this, thank you very much to all of you. Thank you very much.
Thank you.
Thanks
Thank
for the
you, Anita
patience.
madam. Thank you very much for such a nice presentation on standardization of Kshara Sutra. So the take-home message from your slide, I have remembered that this is the area which area and research, that is standardization of Kshara Sutra is the area of research which needs to be explored. But with your lecture today, all the students in the meeting, all of the students as well as the practitioners got sensitized on the standardization topic, and as well as what standards need to be maintained while preparation and while practicing the Kshara Sutra. That also we got to know from the vision of Rasa Shastri. So thank you very much once again for a very wonderful presentation on the
Thank you very much,
standardization.
ma'am. Thank you very much, ma'am. And
Thank you.
thanks to the all dignitaries present here. Thank you.
Thank you. So moving ahead in the meeting, I would like to call upon Dr. Alok Gupta, sir. Dr. Alok, sir. Alok, sir, I think is
Yes,
in the
madam.
meeting.
Yes,
sir.
madam.
Yes, sir. I welcome
Yes,
you
madam. Good evening,
here,
madam.
sir, in
Thank you,
today's
madam.
meeting.
Thank you,
A
madam.
very warm good
Yes,
evening to
madam.
you, sir. And Dr. Alok,
Thank you.
sir, needs no introduction. सर का नाम हमारे क्षेत्र में आयुर्वेदा सर्जरी के क्षेत्र में बहुत उज्जवल है, बहुत ऊंचा है। तो सर हमारे आरएवी के गुरु है, शल्य तंत्र के, क्षार सूत्र के काफी सारे स्टूडेंट्स सर के गाइडेंस में अभी जो है वो सीख रहे हैं, प्रैक्टिस कर रहे हैं। तो और वैसे भी सर का नाम सर्जरी के क्षेत्र में बहुत ऊंचा है। तो आज हमारे बीच सर यहाँ पर उपस्थित हुए हैं, ये हमारे लिए बहुत सौभाग्य की बात है आज के लिए। तो सर मैं आपका बहुत ज्यादा समय व्यस्त मतलब वेस्ट ना करते हुए आपको डायरेक्टली बुलाना चाहूंगी। Today's lecture by Dr. Alok sir is on Chute's procedure. So, sir, over to you. Please take the
थैंक यू
mic.
मैडम, थैंक यू। सबसे पहले मैं इंटरनेशनल वुमेन डे की सबको हार्दिक शुभकामनाएं देता हूं मैडम। और फर्स्ट ऑफ ऑल आई एम थैंकफुल टू आयुष दर्पण एंड डॉक्टर शीतल असुटकर मैडम एंड टीम फॉर गिविंग मी अपॉर्चुनिटी टू प्रेजेंट माय वर्क हियर। आई एम ऑडिबल मैडम?
Yes, sir. Yes.
Okay, madam. Now I am sharing my screen.
Yes, sir. Please share.
Okay, madam. Slides are visible, madam?
Yes, sir.
Okay. Today's my topic is transanal suture ectopexy. That is Dr. Chute's procedure. Madam, I am lucky to have first proctoscope from Dr. Chute to Chute sir. मैडम मैंने च्यूटे सर से ये प्रोसीजर सीखी है और हमारे सभी आयुर्वेदिक फैकल्टी को मैंने शेयर किया है। सो आई एम लकी टू लर्न फ्रॉम डॉक्टर च्यूटे सर।
Yes, sure.
Hemorrhoids are symptomatic anal cushions. These hemorrhoidal venous cushions are normal structures of anorectum and universally present in all persons unless previous intervention has taken place. It is common anal pathology, but many patients are embarrassed to seek medical attention. These anal cushions prominently present at 3, 7 and 11 o'clock in anal canal. The principle of this procedure, there are many procedures available for treatment of hemorrhoids. Now we will discuss 3 procedures which are the gold standard for treatment of hemorrhoids. First one is Milligan-Morgan. In this procedure, ligation of pedicle and excision of pile mass is done and excision is done. Second one is stapler hemorrhoidopexy. In this procedure, excision of lax rectal mucosa and auto-suturing is done. Third one is Doppler guided hemorrhoidal artery ligation. In this procedure, ligation of branch of superior rectal artery done. Then for prolapse, rectoanal repair done. Next one is we will discuss the fundamental errors in Milligan-Morgan. In Milligan-Morgan, ligation of pseudopedicle is done, excision of pile mass is done, and recurrence rate in Milligan-Morgan is around about 20%. Raw area healed by secondary fibrosis, which will create more pain to patient. This is the drawback of Milligan-Morgan. The fundamental errors of stapler mucopexy is strip of sensitive rectal mucosa is removed. Stapling of mucosa is uncontrolled. Mucosa has poor strain, so dehiscence will occur. Rectal volume reduces. There will be hourglass deformity. So these are the fundamental errors of stapler mucopexy. Then fundamental error of Doppler guided hemorrhoidal artery ligation. No definite number of branches are found. On Doppler, only 4 to 5 branches are found. 6 branches are ligated blindly. The plexus cannot be controlled by ligation. In treatment of hemorrhoids, we have to consider 3 things. First one is mass, that is hemorrhoidal mass. Second one is prolapse, and third one is recurrence. In standard treatment, we have to reduce the hemorrhoidal mass by total vascular ligation, and we have to cure the prolapse or treat the prolapse by fixation of reduced mass to rectal muscle, and we have to avoid recurrence by controlling of collateral formation. The transannal suturectomy principle of this procedure is pile mass is reduced by head low and massage, ligation of blood vessels, and fixation of mucosa, submucosa to internal sphincter. This is the principle. In this procedure, 2 circumferential suture line taken at 2 and 4 cm above the dentate line. Procedure. This procedure is carried in performed in spinal anesthesia or saddle block in lithotomy position. In this procedure, stiff head low is given and generous lubrication is done, and massage of pile is done. By compression, reduction of pile mass is taken place. For this procedure, we use specially designed proctoscope that is called Cutes proctoscope. It is a self-illuminating proctoscope having 3.6 cm diameter, and 1/8 circle is cut to form slide flap for operating window. The length of the proctoscope is 11 cm, and it is used for suturing. Again, it is useful to control bleeding from stapler method, secondary bleeding in stapler method. In this method, we are taking suture by 20 vicryl, half circle or 5/8 circle, 27 mm or 30 mm round body needle. The stitches are taken 10 mm long. Mucosa, submucosa are taken in bites of muscle. They are fixed to internal muscle. At least 2 mm overlapping sutures. Starting from 3 o'clock position, not through rectal wall. First circle of suture at 2 cm above the dentate line, and second circle at 4 cm above the dentate line. Changes at the site of stitches. The natural process of inflammation, that is edema, fibrosis, blockage of arteriovenous flow. Suture fixes the mucosa, submucosa to internal sphincter muscle. No collateral formation, no recurrence, no prolapse. This is the benefit of this procedure. Conclusion: this procedure is done above the dentate line, so it is painless. In this procedure, obliterates the arteriovenous feeder of hemorrhoidal mass, so stop bleeding, reduce and fix the mass, no recurrence, no pain. This is the diagrammatic representation. In this procedure, 2 suture line are taken 2 cm above the dentate line and 4 cm above the dentate line. Now we will see the video of this procedure. Dr. Cutes proctoscope is introduced in anal canal. The first suture line is taken at 2 cm above the dentate line, started at 3 o'clock. In this procedure, double interlocking continuous suture are taken from 3 o'clock to 3 o'clock. Now the continuous suture are taken up to 12 o'clock. In this procedure, we should take double interlocking suture. Otherwise, if we are taken single lock, then it will create bursting effect. There may be chances of stricture development. So we have to take double interlocking suture. Now the first row is completed at 3 o'clock. The final knot is taken 2 centimeter above the dented line. Now second row is started 4 centimeter above the dented line. Started from 3 o'clock. Again, double interlocking continuous suture taken by 20 vicryl 27 mm round body needle. Double interlocking. Completed second row also up to 3 o'clock. And this is final knot at 3 o'clock, 4 centimeter above the dented line. Now we can appreciate two suture line, 2 centimeter above the dented line and 4 centimeter above the dented line. Thank you. Thank you very much.
Thank you, sir. Thank you very much
Thank you.
for the
Thank you. madam.
very subtle and very brief and very precise presentation on Chute's procedure. Sir, बहुत ही आपने brief presentation किया, but with the time constraint, as we have seen, we have to conclude with one more very extravagant speaker with us today. So आपको हम बहुत और भी सुनना चाहेंगे सर, आलोक सर. तो आज के लिए
हाँ,
आपको
मैडम.
बहुत बहुत धन्यवाद देते हैं सर. और
हाँ.
I welcome Dr. Mahesh Sanghvi sir in today's meeting. I welcome you sir. Namaste.
Thank you.
यस सो आज के हमारे जो सबसे अवेटेड और सभी स्पीकर्स का बहुत ही एक से बढ़कर एक प्रेजेंटेशन जो चल रहे हैं, उसमें उसी सीरीज में हमारे साथ आज मौजूद है डॉक्टर महेश सांघवी सर, जो कि एक रिनोन्ड आयुर्वेदा प्रोक्टोलॉजिस्ट है, जो मुंबई में प्रैक्टिस करते हैं और हम सबकी इंस्पिरेशन है. हम सबके लिए सर एक बहुत महत्वपूर्ण इंस्पिरेशन का काम करते हैं. हमेशा हम लोगों को एनकरेज करते हैं और हम लोगों से सबसे बेस्ट लेने का प्रयास करते हैं. So I welcome you, sir, and just without wasting time, I would like to invite you for today's talk of yours. Thank you very much, sir.
Thank you very much, Dr. and Dr. Naveen Joshi and my colleagues who are speaker before to me. आज के जो आपकी वुमेन्स डे और कैंसर डे के निमित्त में आपने जो ये उपलक्ष्य रखा है, इसके लिए मैं आपका आभारी हूँ. और एक चैलेंजिंग टास्क मैंने लिया था यूटेराइन कैंसर के ऊपर, क्योंकि हम कैंसर एंड वुमेन के बारे में कुछ बात करना चाहते थे. और मैं खास करके पर्टिकुलर हेमंत का शुक्रगुजार हूँ कि उसने मेरा बहुत काम आसान कर दिया है. और मैं जो कुछ करता हूँ और क्या मैं सलाह करता हूँ उसके ऊपर मैं ज्यादा बात करूंगा. लेकिन हम अगर जब बात करते हैं तो फीमेल रिप्रोडक्टिव सिस्टम्स के बारे में थियरी के ऊपर मैं नहीं जाऊंगा, आप सब लोग जानते हैं. और नहीं तो इट इज बीन अवेलेबल एवरीवेयर इन द वर्ल्ड इन एनी मीडिया. नाउ द इंडिकेशंस अगर हम देखते हैं तो 90% यूटेराइन कैंसर्स जो है वो ओरिजिन फीमेल में एंडोमेट्रियल पाए जाते हैं. वर्ल्ड में जो है ये 4th है, और इंडिया में जो है वो अपने को कैंसर जो है ना सेकंड लीडिंग फीमेल्स के अंदर में ये पाया जाता है. ये डाटा नेट से मिला है और उसके रेफरेंसेस भी है. नाउ यूटेराइन कैंसर्स की हम जब बात करते हैं तो उसमें एंडोमेट्रियल कैंसर्स एंड सर्वाइकल कैंसर्स रहते हैं. टुडे आई विल बी स्ट्रिक्ट विथ माय दैट in time in uterine cancer only. Now, what are the risk factors? क्या क्या हेतु हो सकते हैं उसके बारे में हम जब बात करेंगे तो इंक्रीज द एस्ट्रोजन, यानी कि प्री मोनोपोजल मोनोपोजल सिंड्रोम्स के अंदर में ये जो है सबसे ज्यादा पाया जाता है। हार्मोन थेरापी लॉन्ग स्टैंडिंग अगर हम लेते हैं तभी, ओबेसिटी, ओल्डर एज, इनफर्टिलिटी, जेनेटिक्स एंड बीपीए, एचपीवी वायरस की इन्फेक्शन है, एंड सबसे मोस्ट इंपॉर्टेंट है एंडोमेट्रियल हाइपोप्लेसिया। मैं यहाँ पर आयुर्वेद को अगर जोड़ना चाहूंगा तो मैं ये कहूंगा कि ये पेल्विक फ्लोर डिसऑर्डर्स है और अपान वायु की विकृति के साथ में दूसरे सारे बहुत सारे संबंध जुड़कर ये बीमारियां होती है, और उसमें एक एसटीडी भी है। अभी सिम्टम्स के बारे में जब हम देखते हैं तो वो इरेगुलर मेंस्ट्रुअल साइकिल्स, ब्लीडिंग बीच बीच में हो जाना, प्रोलॉन्ग मतलब जो पीरियड्स ऑफ ब्लीडिंग बिटवीन द पीरियड्स आल्सो, difficult for the painful urinations, back pains and swellings in legs and everything. But the most thing is that it give you and incomplete evacuations in urine and stool also. Now, pathophysiology, if you'll go to the endometrial cancer forms, these are the error in the normal endometrial cell growth. यहाँ पे मैं एक संस्कृत का श्लोक कोट करूंगा जो अक्सर हम लोग जानते हैं, शरीर की जब हम व्याख्या करते हैं तो श्रीयते श्रूयते इति शरीरम, यानी प्रतिक्षण नए सेल बनते हैं और प्रतिक्षण एक सेल जो है वो खत्म होते हैं। लेकिन जब सेल जरूरत से ज्यादा उत्पन्न हो, डेड न हो, या तो वो डेड होने की प्रोसीजर में उसके अलग अलग जो मॉडर्न लेवल तय किए हैं उसके ऊपर उसका डिस्ट्रीब्यूशन नहीं होता है, तब जाके जो है कैंसर होता है। ये एक मेरी खुद की मान्यता है और ये प्रैक्टिकली भी मैं देखता हूँ। जब हम डायग्नोस्टिक पैरामीटर्स की बात करते हैं तो उसमें सबसे बेस्ट है, आपको जैसे अहमद ने बहुत अच्छी चीज की थी, आई बीन इम्प्रेस विद दैट, अ गुड हिस्ट्री ऑन द टेबल will be help you to assess how to exam, what to exam and everything. तो उससे पहले जब हम देखते हैं तो पहले palpitations of the abdomen है, फिर उसके बाद में PV examination है, and when you found, then you can prescribe the modern diagnostic parameters, and one of the safest, easiest and most reliable is parameter is transvaginal USG. Then another one is hysteroscopy. You put the scope inside, you can see and you can take the biopsy also. Then biopsy, it has been already be described, you can take it, put up inside and outside, very small punches there, and the biopsy will confirm of the stage and the, the type of cancers you can get it there. One of that one, the CT scan compound, one of the best tool to see it that where there is in any more pathology around surrounding or that need this own CT. One another is MRI, and third is PET scan. Why I advise the PET scan? When it has been secondary metastasis or you doubt with the patient's clinical symptoms and history, then you always, before the plan treatment, you should have to go for a PET scan. It is a localized, or it has been attached with the associated organs, or it has been spread in other organ also. That will be give you a chance to plan how to treat the cancer patients, particularly uterine cancers. Now, this is one of the best, one of the colposcopy that has been done by the gynecologist. It has been very, very useful for the cervix, difficult to put into sight into the, the uterus. But for the cervix, colposcopy is one of the best, and that can be, you can visualize it and you can take a biopsy also. Now, one of these blood tests is that CA-125. This is a cancer antigen agents, but if it is normal and borderline, you should always suspect because it is in a statistical data. And if it is very high, then you can suspect it may be, the multiple metastases you will find. So these are the parameters which can be helpful to the diagnosis of the cancers of uterine cancers and other cancers of the reproductive systems. Now, if I come to this stage 1 and stage 2, these are found only in the uterus and total hysterectomy and bilateral splenography, that will be with co-formatic operation will be find out the treatment, stage 1A and stage 1B. Here I'll come out how Ayurveda help us and how I advise my patient in the, later on. This is stage 2. This patient is been both in the uterus and cervix. Radical hysterectomy has been advised and it has an excellent result along with the other associate. Now this one has been, the more difficult to treat the patients, and it has been more advanced in a stage 3 patient. So then it's been milking surgery, and additionally you should have to remove the positive as much as the lymph nodes, and you should go for an prior to the radiotherapy, it would be better. And if you have a good oncologist chemicals, then you can give pre-operative chemotherapy with radiation, and then you can do this one. Recurrence is late and the post-operative complications has been very less. And now this is stage 4B and 4A. So these are been, the advance. It has been attached with the bladder, it is attached with the colon, it is been spread into the liver, lungs, and anywhere. So that only the bulking surgery, which help only to give a palliative medicine, not a curable. In this case, radiation is not possible. Only little bit helpful is that maybe, and the chemotherapy will be helpful to these patients. Now, surgery that are in a partial hysterectomy, total hysterectomy, and radical hysterectomy. Total hysterectomy has been, they have been a good result. Radical hysterectomy in stage 3 and partial hysterectomy, it is in a stage 1. But the statistical data says if you remove whole, if it is not necessary uterus, then it is been better, because when you remove this one, you don't know how much other cells are being affected with this, the cancer cells, and cancer procedures is been in the cellular level is as it is. So therefore, what since last 10 years we are working with this oncologist, we give first 3 chemotherapy, then operation, then chemotherapy, and SOS, we give some heat, Agni Karma, जैसे उन्होंने बताया था, तो we give the, the laser heat on the operated parts, so the remain small particles is been there, it has been come out. Now, why should I give chemotherapy before that operation? Because when you operate, the cell, cancer cell is being accumulated with the blood, it has been traveling the whole over the body, and what human system has been disturbed, it is deposited somewhere, and it gives you a secondary metastasis. So these are under observations, multinational, the states, and Cancer Society is working on this, and primary report has been excellent and very good. Now, here, how we can help them. So what, the chemotherapy has a side effect, and your counseling is more important to the patient, which we do the better than any other people. Number one, and there are a lot of side effects of the chemotherapy we will later on, and how we can help to them in the integrated approach and give a better result, and human services along with the integrations. And this is the surgery another which I have been explaining what as much as positive lymph nodes you have to remove as much as you can. And if it's not there, then again, if it has been diagnosed before the surgery, give chemotherapy, control this one, and then you do the surgery, and then again give you a 3 or 4 required chemotherapy as an excellent result. Now, radiotherapy is one of this best one, and there have been modified, the apparatus is there, and you can fix on this, the tumor cells, or you can send a growth, or you can in a cancer pathology, and you can do it. But every pathy has these side effects, and this has been known as a brachytherapy. When I have been told that brachytherapy, where the patient cannot be operated, it is not improved with this, the surgery or in chemotherapy. So you can give enough primary focus. If you can burn it, might the procedure of cell and it will be growth we can reduce it. Here also we have a lot of role in radiotherapy complications. We will discuss in the next slides in the end of this one. And one of this one is in every stage there is an hormone therapy, and we can have to lose, the maintenance over the prostogen given in a pill form. Type, dose, and everything is depend upon the stages 1, 2, 3, 4, and that should be decided by the endocrinologist or the chemotherapist. We should not prescribe this one, but we should understand that this is the one of the treatment which helpful to the treatment, and it give you a better result after surgery, after everyone. Still there is a pathology. I hope so hormone therapy will give you a better result to maintain the prostogen in the blood level in the body. Now chemotherapy, that is the best one. Sushruta said surgery is the best, but before that there should be some medications which is been here. I will put as a chemotherapy as an Aushadha Chikitsa, and it has also a side effect. Now I have learned from Dr. Sardesh Mukhi Pune couple of years back. He gives some Ayurvedic medicine to the cancer patients and for the particular complications. So if you see it that they lose the hair, they have a vomiting sensation, they have a diarrhea, they have fatigue syndromes, everything. Here, pre-operative and post-operative. What my practical experience is, on the day of chemotherapy and after 48 hours, and before that for 8 days, we have a protocol of the chemotherapy complications medicine. It works excellently and it reduces the complication. Nowadays also the molecular has improved. They have added some medicines before and after that. It also reduced, but still there is there. And here we have an excellent role. And I request to all these centers who are in surgical and they have a practice to in a surgery or a chemotherapy centers, they have to try this one, and you should have to prove the Ayurvedic medicines. Second thing is in radiotherapy, it gives you a burning sensation, it gives you an ulcers, it gives you a bleeding and everything. At that time, we can have an excellent role in this one, and you can get a better result. This is another one, which is our role. And now the prevention is always better than cure. Nowadays, vaccine is available, and they say that 60% they can control this, HPV. And there are 2 stage, 3 dose, 6 dose, they decide themselves, and 70% and cervical cancers they can prevent. It is been, the claim international data. But still nothing is better than something, and it has no more side effect. So I'll request every surgeons and gynecologists to look after that about the vaccination, like, we can take an hepatitis B and other, the vaccines we take ourselves to protect the disease and its complication. And I think so this is in future, it give you a better result with the research by the modern science. Now, always prevention is better than cure. So then what you have to do, you maintain your weight, regularly weight out, आप अपना वर्कआउट कीजिए, and regular checkup कराते रहिए. Extremely said, my previous callers, कि हमारे वहां पर इंडिया में लोगों को रूटीनली चेकअप करने के लिए बड़ी आफत है, समझाना बड़ा मुश्किल है. तो उनको रेगुलरली आपको बताना चाहिए, like an pap smear, USG, breast, the examination, something like that. And if it is needed, hormone therapy, and avoid long abuse use of the birth control tablet, because it's hormones with disturbed. So that about it has been sure that an awareness, we have to improve the patient awareness, medical health services to the common people, particularly the females. That will helpful to prevent the disease, and we can reduce the statistic data of this one. So these are the endometrial and uterine cancers, cervical cancers, and human papillomavirus. You should have to be examined. Breast cancers and ovarian cancer, which are the most common in this one. And you should have to take care. You have to educate the patient how to examine them, what are the symptoms, where you have to go for the ultrasound sonography, and when you have to go for a CA 125. If we will adequate this one, I wish that we can give you a quality of life to the every patient. And before 50 years of age, we should have to think about HPV. So thank you very much. Tomorrow we have a Holi festivals. Hopefully adds more color to your life and your patients. I'm thankful to organizer Archana and Ayush Darpan and Dr. Joshi. And I'm most thankful to Dr. Gaurav Gupta, who is the MD scholar from YMT. He has been made this beautiful design, and presentation is been given by nephew Rasika Chopra. Thank you very much. Thank you very much again and again. Thank you. I hope so I am before time.
Yes, sir, you are very much within time, and thank you very much to you for such a nice presentation on occurrence of cancer in women. So ये बहुत ही befitting presentation था आपका आज के इस इंटरनेशनल वुमेन्स डे के प्रोग्राम के लिए, और दैट टू आज के सारे ही सभी स्पीकर्स, इवन आई वाज सपोज्ड टू डिलीवर अ प्रेजेंटेशन टुडे, बट मैं जो सुन रही हूँ आज आप सबको, तो बस मैं सुनती ही जा रही हूँ, एंड आई थॉट कि आज का दिन जो है वो मेरे सुनने का दिन है, और आप सबके मेरे इस प्लेटफॉर्म के ऊपर सबको हम लोगों को उद्बोधित करने का दिन है। तो थैंक यू वेरी मच। किसी और दिन मैं इस प्लेटफॉर्म पे कर सकती हूँ प्रेजेंटेशन, बट आप सबको सुनना आज हम सबके लिए एक बहुत ही गौरव की बात रही है। तो मैं डॉक्टर नवीन जोशी जी का शुक्रिया अदा करती हूँ, एंड आयुष दर्पण फाउंडेशन एंड महात्मा गांधी आयुर्वेद कॉलेज हॉस्पिटल एंड रिसर्च सेंटर की ओर से मैं आप सबका बहुत बहुत शुक्रिया अदा करती हूँ कि आपने हम सबके इनविटेशन को स्वीकार किया, और यहाँ पर बहुत एक से एक उम्दा आपने प्रेजेंटेशंस यहाँ पर प्रस्तुत किए हम सबके सामने। तो आई वंस अगेन थैंक यू thanks to Dr. Mahesh Sangvi sir, Dr. Alok Gupta sir, Dr. Hemant Kumar sir, Dr. Manjusha ma'am, Dr. Anita ma'am, and all the students and practitioners in the meeting, all the seniors in the meeting, to the cadre of Dr. Dr. Rajesh Kumar Gupta sir, Dr. Amar Dwivedi sir, एंड अगर मैं किसी का नाम भूल रही हूँ तो मैं उन सबको यहाँ पर मैं मतलब उल्लेख करना चाहूंगी, और मैं गौरवान्वित महसूस कर रही हूँ खुद को यहाँ पर कि इस मीटिंग में आज मौजूद है, और हम सब ने आज की इस टॉक शो का, इस लेक्चर सीरीज का फायदा लिया, बहुत बहुत फायदा लिया, और बहुत हम लोग यहाँ पर आज मतलब इस बात का हम आज टोटली फायदा ले सके, हम अपनी प्रैक्टिसेस में भी आज इनको जो है हम लोग प्रैक्टिस में इनका फायदा लेंगे। सो थैंक यू वेरी मच, थैंक्स वंस अगेन टू ऑल।
बोलने वाली किस विषय पे थी डॉक्टर साहब, हम भी तो सुनने, विषय तो बोल दो।
मेरी प्रॉक्टोलॉजी पे केस सीरीज थी सर, जो मैं यहाँ पर प्रेजेंट करना चाहती थी, बट ड्यू टू टाइम कंस्ट्रेंट आई कैन नॉट कंटिन्यू फॉर टुडे, बट डेफिनेटली इन सम डे इन द फ्यूचर आई वुड डेफिनेटली बी प्रेजेंटिंग इन फ्रंट ऑफ ऑल ऑफ यू। सो थैंक यू वेरी मच।
थैंक यू। तो आपका अगली बार जब भी सीरीज होगा तो आपका प्रेजेंटेशन
नहीं, डेफिनेटली ये हमारे लिए कोई बहुत ही गौरव की बात है आज के लिए, बट मैं सभी का शुक्रिया अदा करती हूँ, और आप सबका बहुत बहुत धन्यवाद। थैंक यू वेरी मच।